Now this is fun. I get to moderate Q&A with 3 really smart and funny people. So we'll have a good time here for the next 45 minutes. We have some really good questions on the live feed, but we have a mic up, I think right up there somewhere. We have a couple mics. If people have questions and want to just walk on down, and we'll kind of alternate between the live feed and people with questions. Yesterday at my talk, I had the slide that said make fat great again, and then here's the hat that wasn't in my bag, make healthcare great again. I think that's why you guys are here. There's probably 15 different medical fields here, and patients and educators, so all of us together hopefully will make healthcare great again. This isn't a political statement, this is medicine. All right, on we go. Okay, and we'll try to kind of mix these up. David, if you had to write bio diet today, what's something new that you'd include and something you'd leave out?
See, I kind of when you're in the creative process, you're open to those things. Once you've finished, like the film we're going to watch tonight, then everything is perfect. The reason I enjoy this is it's always a learning experience. It's a continuing learning experience. So even some of the things that I've learned over the last 2 days, I would include some references to those. If I was going to leave something out, we left a lot out. It was originally about 1,200 pages that we honed down to about 230 pages to make it consumable. So I'd like to kind of think that we took out all of the stuff that maybe would make people's eyes roll back in their heads if we were talking too much science to make it more approachable. So I'm going to take a pass on the second one, but on the first one, again, I think always learning and always being open to learn is an important part of the process. We're never finished doing science. We're always continually doing science.
Good. Ivor, would coronary neovascularization be similar to diabetic neovascularization in the retinal arteries of diabetics?
Yeah, I'd say broadly speaking, yes. Neovascularization responds to signals of distress generally, where vascularization is needed to bring in various blood components. So I guess that diabetic eye is certainly suffering in many ways, and it would be a similar analogous situation.
And Eric, this one was good. For the people eating 1 meal a day, what does that meal look like?
I'm glad I have the easy ones. 1 meal.
Throw you a softball.
They really need to be nutrient dense, and shellfish would be awesome. I think eggs are really, really good. Not 45, but maybe 4 to 5. And then I do recommend mixed greens. I don't really like spinach too much because of the oxalates. And so, honestly, just between you and me and the 4 walls, I have all my greens in one sitting. It's basically probably 7 to 9 cups. And it's not that hard. I cut it down, I eat that. So you have the greens. I have avocado. I like beef. I like different forms of beef, hamburger, grass-fed, grass-finished. Eggs, and then the greens. And I do a lot of fish for trace minerals and the omega-3 fatty acids. So if you take a look at a plate, half the plate should be like maybe greens and stuff, and then half protein, or the corner of it would be protein and then fat. But the fat and protein are usually together.
And one more for Eric. This is a good question. What should carnivores supplement to do the best nutritionally? Mm-hmm. Or do they need to? Should they?
I think it's going to be difficult to get certain things, but you could definitely get the zinc and the B12, but potassium might be a difficult thing unless you consume a massive amount. I don't know how they're getting the potassium. So if you substitute with potassium, probably magnesium, and also you're going to get, if you do like liver and things like that, you'll get the B vitamins, all the B vitamins, vitamin C and folate, but realize that your body does make folate, and it makes biotin as well if you have. But the problem is a lot of people are doing carnivore and they already have digestive issues. It's compromising. So they might not be making all these vitamins. So they might need to take some nutritional yeast to get the B vitamins. But I think that the vitamin C would be important. that would be it, and the minerals.
People, feel free to come up to either of these aisles if you have questions. We'll get you a mic. Ivor, why drugs that raise HDL have been a failure, in your opinion?
Yeah, so the CETP inhibitors, so I think what's important with HDL is HDL efflux capacity, which is essentially HDL functionality. And an amazing human study they did in 2015, they got a whole range of people, they got their HDL, and in a laboratory assay, a brand new one, they tested the ability of each person's HDL to efflux cholesterol out of macrophage. So they found effectively they found their HDL functionality level. And then they followed them for many years. And lower HDL people had 30% more heart events, which you'd expect because lower HDL indicates it's not so functional. But the people with the lowest HDL functionality, which was measured in the lab, had 70% more events. So it's stressed that HDL functionality is the important thing. So when they go and they use chemical cattle prods, I think I've heard it said, to force HDL to go up and LDL to go down, you know, you're trying to mirror something, but you're not mirroring it at all. You're not improving HDL functionality. All you're doing is pushing the deck chairs around on the Titanic. So I think they were quite naive with the mechanisms they were exploring when they invested in those drugs. And I think with the knowledge we have nowadays, they could have predicted they were going to get poor outcomes. So HDL has to be raised through becoming healthier, and then have your higher HDL reflect a better HDL efflux capacity. And that'll be through nutrition and lifestyle. And you ain't going to get it from a bottle of pills, at least not yet.
So we'll go. We have one right there. Mike Donald.
Okay, got it, sorry. My questions have to do with timing. What, between the insult, how long in years does it take for the vasovasorum to start growing in and causing problems? And if the does the ketogenic diet reverse plaque formation once it's established? And over what time period?
That's a wide-ranging question. Two questions. So the first one, what time does it take for the insults? It depends on the extent of the insult. So a raging diabetic with massive hyperglycemic swings and huge insulin, you know, the time is going to be shorter. Within a few years, I'm sure the intima is going to be screeching. Someone who has a lower level of diabetes, it might be much longer. But also I'd have to say we are finding people now, even a gentleman in the audience yesterday, who has been diabetic for 10 or 15 years, extremely overweight and middle-aged, and came in with a 0 calcium score. So there are genetic resistances to this disease, just like there are genetic susceptibilities. So the person who actually ate reasonably well didn't do bad things and ends up with huge atherosclerosis. So it's an extremely hard question to ask. The thing is, the CAC scan gives you the ultimate end answer of your life to date. So I have a 29-year-old with mild diabetes in the US with a score of 600 with the arteries of an 80-year-old. We've got a 73-year-old with a 0 score and a clear angiogram. You know, and it's very hard to tie your lifestyle to your exact result. You just need to get your result and then accept whether you're very high risk or low. And that gets into the second question. So you get a high score regardless of what you did in your life. Maybe you have a family history and a predisposition. So you had a pretty good life, but you still got a lot of disease because you were susceptible to this disease process. Well, you got to take action. Now, I'd say low-carb keto is one part of the action, and because most heart disease relates to diabetes and high insulin and glucose, not all, but most, obviously low-carb and keto are going to be a big spar or a big lever in helping. But then I think there's a lot of other things too for the most diseased people, getting high in magnesium and maybe K2, potassium, getting UV sun exposure for nitric oxide to heal the arteries. Multiple other photo products come in as well. So there's a whole range of a multi-factor intervention that I would use if I had a high calcium score to ensure I was going to arrest the disease process. And in terms of reversing plaque, Dr. Agatston unfortunately couldn't be here because of the challenges, but we had a great discussion that's on YouTube. And his opinion would be primarily soft plaque that are beginning to calcify with spotty calcification. They will actually reverse if you do the right thing and you stop what's driving the disease. But dense old plaque that are fully calcified won't tend to lose their calcium back into the system. We see it happening sometimes, but the key thing is to stop the progression. You don't need to reverse the score. Stop it or slow it to below 15% per year, and you consider that you've arrived, because most people not doing anything ramp up their calcium right up until their heart attack.
Thank you.
No, go ahead. Next question.
Hi, I'd like to learn more about the index that substitutes for the BMI for David. Could you tell a little bit more of that? What are the desired ranges, and whether there's any relation to prognosis or outcome or metabolic disease?
Yeah, thanks, and I'll repeat the question. I think the question is, I objected to the use of BMI, and you're asking me about the other ways to do that. Is that correct?
You relate to the height with the
yes.
the waist circumference, I think.
Yes.
Can you tell more about that?
So, so as a kinesiologist, and also my background in biomechanics and mathematical biofluid dynamics, we look at different sort of morphologies all the time. It's kind of my passion, and BMI is just a really lousy indicator. It's arbitrary, and you can get people that are very muscular that have BMIs that would put them into the overweight or obese category, and they're totally healthy and have no body fat. So what we want to look at is the body fat percentage, and there's different ways to do that. The way we do it clinically is with a DEXA, which is dual X-ray absorption. Oh boy, absorptiometry. It's a tough one to get out. And what that does, it's a low radiation scan of the body that tells you the densities. I actually use it for bone density as well, so you get that score. And that tells you not only how much fat you have, but where that fat is on your body. And of course, the place you don't want it is in that mid-abdominal region, because that's where that visceral fat and also the fat in the liver contributes to inflammation and all kinds of other things. So, that's the way we do it clinically. If you want the best measure, and I'm sorry, their names escape me, but there's two researchers at Cedars-Sinai Hospital, it's in the book, and they've come up with something called relative fat mass. So you can just Google that, you'll see their paper. It just came out, I think, in 2018 or 19. And all it uses, they actually looked at a whole bunch of different morphological measurements, and then they compared that to scores from clinical work to see how those morphological measurements would compare with the clinical results. And what they came up with was something really simple. It's just, all you need to know is your height and then your waist size. And it actually, if you look at their statistic, it's pretty darn good, PDG as we say. And so the calculation, it's a simple one-line calculation. It's not just height divided by weight. There's another little factor in there, and it's different between men and women. But that one is really good and really easy. Everybody can do it at home, and it's a pretty good estimate of your relative fat mass. And again, what it focuses on is that mid-abdominal visceral fat that we don't want. So when I'm counseling patients and when I'm counseling clients, they're always telling me their weight, and I say, I don't really want to know your weight because that can fluctuate tremendously with water and so on. What I want to know is your waist size. Because if we're doing something that's effective on reducing their waist size, then we're having the positive effect. And for sure, when I get papers to review scientifically and they're using BMI, I generally reject them and I ask them to use something more appropriate.
A couple other simple measures there to do. It's 2 times your waist should be less than your height. And in the little guidebook we have, a lot of people don't do waist circumference correctly. So you put it at the belly button, have them do a little do-si-do, but you have to do that correctly. And in West Virginia, we kind of have some low-tech methods. I had a patient come to me one day and he said, Doc, for the first time since I could remember, I could see my friend in the shower. So that was so I think he's going in the right direction. And a lady came in one day and said, Doc, for the first time since I can remember, my waist size is less than my chest size. So they could be some of your old school measures without
Thank you.
fancy stuff. So use the technology you got. Next, is that Bill? I think that's Bill.
Yeah, this is Bill Errico, family medicine doc. So this message is for, this question is for Ivor. I really appreciate your presentation. It's very thought-provoking from a physician's perspective, as well as tying it in with Dr. Ali's yesterday. My question is, because it's easy for doctors to avoid the use of statins in people without established coronary disease or people with a 0 score that have high LDL, it's a little bit more accepted in the community or in the medical community to do lifestyle measures first. But in patients, I have many patients with established coronary disease, either by CAC score or angiogram, that have maybe abnormal stress tests that have been stented. In that population, and just thinking about your presentation, by obviously not ignoring the lifestyle modifications you're going to do, if you're also going to go to the extra length at lower LDL with pharmacologic measures, either with a statin or a PCSK9 inhibitor, if you're doing those things, which are actually kind of orthodox in the community, what do you suspect happens with the graphic you used about the influx of LDL in response to injury and not the cause of injury? What do you suspect would happen or theorize would happen by dramatically lowering LDL in regards to what would happen in the intimal wall?
Okay, good question, yeah. So I haven't thought too much about that, and I don't engage too much with pharmaceutical side of the house, more interested in the root causes and addressing them. But I would say that it's a fair, and I've always stated with statin mitigates events or defers events, but heavily in the people who have significant disease. And we're seeing the latest studies, like you said, like last year, 0 scorers, a number needed to treat might be 500 people to get one person to benefit. And then high scorers, people with prevalent disease, it could be as low as 20 or 30. So the statins do reduce the problem, they mitigate. And I think it's through anti-inflammatory pathways and many different pathways, but I'd also acknowledge the statins do lower the substrate, the number of particles. And I would guess, as Subotan would acknowledge, that lowering the number of particles could mitigate that process I described. So I think it's okay that the statins also work through lowering the number of particles as well as the pleiotropic pathways. But the statins are so much a personal decision, because you need to talk to your doctor about your disease level, how much you've changed your diet and lifestyle and may have addressed the root causes adequately, and what your likely number needed to treat is. How much benefit will you get versus potential harms, which are acknowledged for a statin, not huge ones. So it becomes a personal decision. But back to the diagrams, I think it's reasonable that if you really lower the particle number, you will spancel or curtail the process of atherosclerosis and possibly lower events through that kind of vector. But you know, it's hard to have a clear answer on it because there's a lot of pleiotropic action going on with statins, and even PCSK9, a recent paper has shown that it links very much to an anti-inflammation pathway as well as to the cholesterol lowering. So it's quite a murky area.
So then if you're using HSCRP maybe as a marker, or uric acid as a marker, or things like that, is that something you can follow, or something maybe you'd recommend following regularly by putting the patient on the statin? At least you have another. I'm just trying to think about different things you can do if you're placing someone on that to kind of show them that they're making progress, and not just say LDL's low, but are they making progress?
Well, there's a couple of really, you reminded me there on HSCRP. So there's a couple of studies that have actually demonstrated in humans with statin treatment where they've tracked ferritin and I think CRP also. And they actually noted that the lowering of events, when they went through the individual level data and did a proper analysis, the lowering of events tied directly to the degree that the serum ferritin and the CRP reduced, but did not link to the degree that the LDL reduced. So they were quite powerful papers indicating beyond the LDL lowering effect, the statins have this effect on iron metabolism, have an anti-inflammatory effect, have a plaque stabilizing effect, even things relating to clotting. So I think, if CRP and ferritin, which is an acute phase reactant for inflammation, are dropping, that could be further confidence that the statin is having multiple effects, as well as the lower LDL. But these medication decisions, I kind of steer clear of them. They're for doctors. I'm not a doctor.
That's why I say the
Dr. Ali is right behind you. He can give his opinion.
Yeah, that's why it's so difficult with patients with established coronary disease, because
Well, one last word. My sponsor, David Bobbitt, obviously a 1,000 score, he had multi-vessel disease, 90, 70 blockages, no operation, no stents, lifestyle, diet and meds, and he takes the statin still. And his approach is, look, he thinks that the lifestyle changes and controlling his newly discovered diabetes are maybe 90-95% of his event avoidance. But he wants the last 5 or 10% the statin affords. So he's going belt and braces. But again, it's a very personal decision for him. No doctor's going to tell him what to do, believe me.
Right. Thank you.
Yeah, hi, I'm Richard Morris. I've got a question for Professor Harper. You spoke about cancer cells being obligate glucose consumers because they've lost OXPHOS, and I understand that one of the hallmarks of a mitochondria in a cancer cell is a high delta psi. It's proton. It maintains protons in the mitochondrial membrane, in the mitochondrial space. And I'm curious how, if you have any ideas about how it does that, if it's not using OXPHOS, if it doesn't have NADH and FADH from the Krebs cycle.
Well, I would rephrase the question if I had the expertise to answer. That's a very specific biochemical question, but it's about the protein flux in mitochondria and how that might change in cancer cells, or? Yeah,
so there's one of the observations in mitochondrial cells and cancer cells is they maintain for some reason a high delta psi. Yeah. They keep protons in that space, and I'm wondering how it can do that without OXPHOS.
Yeah. So again, going back to basic, biochemistry, it's that flux, that move of protons that actually drives the production of ATP and so on, and that whole process is shut down much earlier in that stage. So all kinds of end metabolites are going to start building up in ways that they normally wouldn't in a healthy mitochondria. But it's interesting, that mitochondrial question, because they are kind of like little frenemies within, in that they go through their own senescence and so on. They cycle. They don't live forever, and exercise will help improve them. In fact, there's much talk about autophagy around keto and intermittent fasting, but I think even more important is mitophagy, which is to cycle the mitochondria in a healthy way. And the best way to do that is exercise. But ketogenic diets supply, through beta oxidation, the fatty acid fuels, which burn with much less reactive oxygen species, which is better too. Now, I'm going to take another leap here and talk about some of Thomas Seyfried's work with Dom D'Agostino, looking at nuclear transfer to show that, in fact, it looks like, in their model, which is with mice, that mitochondrial changes happen first, that then affect nuclear changes, that then affect the activation of oncogenes, that then have the cellular changes that lead to proliferation of the cells. And he did, it's kind of complex in this time we have here, but you swap them, and it turns out that it's the mitochondrial changes seem to happen first. So sorry, it didn't specifically answer your question, but I think you're asking the right kind of question, is to look at mitochondria in terms not just of cancer. See, I don't view cancer as a different disease from diabetes or cardiovascular disease. With my friend Ivor, design thinker, we look at root cause. And I think the root cause of I think they're the same disease. They're just manifesting themselves in different ways. And the disease is unhealthy mitochondria. So thank you very much for the question.
Thank you.
Dr. Ali.
So, Ivor, that was a very diplomatic answer, and I almost thought for a minute that you were a statin proponent. So the pleiotropic effects of statins are actually promoted a lot by the statin industry. But really what pleiotropic effects really are is dysfunction of the insulin receptor leading to diabetes, the calcification of the coronary arteries, the reduction in antioxidants that our body elaborates. So all these pleiotropic effects, which are the negative pleiotropic effects, are not actually propounded by many people. And I think we should create a balance with that regard. So that's why I made this comment. Sorry.
No, that's fair enough, Nadir. And, you know, I'm just careful in this discussion about statins, and I don't want this statin denialist kind of slur thrown at me, because, like, I focus on root cause, and I'm less interested in statins, and I'll roll with the fact that the trials did show some benefits, you know, and they saw CRP and ferritin reduce, which kind of indicates lower inflammation, but these are short-term trials. And then the negative impacts could be longer-term things. So for me, I just don't really engage with it. If I had high disease, would I take one? Well, I'm guessing I'd go with my knowledge, and I'd go after root cause, and maybe I wouldn't go belt and braces, but that'd be a personal decision. Yeah.
I'm going to grab a couple off of the line here for Eric. This one came up a couple times. Lab values cite fasting insulin of 1 to 2 as too low. If insulin sensitive, is that too low?
So you're asking this?
Yeah, the reference range, when you get it back, it'll be, you know, it'll say it's low or too low. You know, in the standard lab panel you'll get. But is that really, if someone's insulin sensitive and well, is that too low or
It really depends on, I would look on how the patient feels, because they're adapted so much. They're running on a lot less insulin. And I would just, same thing with hypoglycemia, like if the blood sugars are 58 and they're feeling great, and like, okay, so you know what? You're not using all that glucose anymore, so the need for insulin goes down. So I would look at the whole picture, and I wouldn't go too crazy about, oh my gosh, we need to raise insulin now, especially if they're feeling great.
No, that's right. A couple on vitamins too. So better clarify the role of K2. You know,
Yeah.
Anyone could really, any of y'all could chime into that one.
Yeah, K2 is all about transporting the calcium from the soft tissue into the hard tissue, into the bone. So it works with D3, which increases the absorption of calcium, and then K2 takes it the rest of the way. So obviously it's really important in protecting against soft tissue calcification in the arteries. But I also know that it works in the mitochondria. I know that a lot of people who take it, they have a lot more endurance when they exercise. So it has multiple benefits, but it's definitely something that if you go on a low-fat diet, you're going to starve yourself of the K2. And if you do high D3 without K2, that could be a problem.
Yeah. And one more on potassium. So is there any real upper limit on potassium supplementation, and does the lab value reflect your total body potassium?
Most of the potassium is intracellular, 98%. There's a great test you could do. It's an intracellular test for potassium and even magnesium as well, because evaluating potassium in the blood is kind of worthless. You can get some data, but it doesn't tell you what's really happening. The kidneys have great ability to get rid of excessive amounts of potassium. I have a lot of the textbooks on potassium, and that keeps coming up in the research. You don't retain it like you do sodium, so you could take a lot. Even, I guess, back in evolutionary times where you had consuming a tremendous amount of potassium. I mean, there was some reference to consuming like 11,000 milligrams of potassium back then. So I think there's so many benefits when you increase the potassium. All of a sudden their blood pressure does better, the arteries are more elastic, the fluid comes down, it even improves insulin resistance, it speeds up the repair of insulin resistance. So it just has so many positive things. So I wouldn't worry about taking too much unless there's a kidney problem.
No, good,
Yeah.
perfect.
I was wondering about intermittent fasting. When you just fast once a day, are you asking people to get their full day's caloric intake of what they would normally take in several meals into one meal, or just to eat until satiety?
It's really hard to consume, like when I eat 3,000 or 3,000 calories a day into one meal. So no, it's going to come down, but the efficiency of the nutrients are going to be much better, so the need for the RDAs go down. So you're not going to need as much nutrients because your body's going to recycle and conserve them, especially even with protein. Fasting is more protective on protein loss. But I would really go not on just counting calories. I would go with what the person can digest without feeling completely stuffed and uncomfortable, but make sure they're nutrient dense. So it's a real individual thing. There's so many variables in how many calories someone needs: the age, the metabolism, male or female, if they're exercising, the ability to absorb it. So it's really hard to predict exactly what that person needs.
This is directed at Ivor. Two things. First, the question about inflammation and LDL. There was actually a really neat study that was reported in Kidney International 2018, Story et al., the Sharp Collaborative Group, and they asked that question. It's a study of heart and renal protection, and they asked the question: do you get a benefit of LDL versus inflammation, or is it independent? And very interestingly, what they found was, with every 23-point increase, this is US units of LDL, there was a 14% increased risk of major vascular event, but a 4% decrease of non-cardiovascular events, okay, in that. And they found that independent of inflammation. Just a side note too, so that's a really good study. When you look at the risk of metabolic syndrome or type 2 diabetes, the risk of a major cardiovascular event is 240 to 600%. So if you took their own numbers, your LDL would have to be between 500 and 1,000 to reach the same level of risk, just using their own numbers as a metabolic syndrome or type 2 diabetes. So I find that a very good concrete way, talking to my colleagues, I'm a physician as well, about the absolute, like a real objective way to objectify the risk of LDL going up versus metabolic syndrome or a slight increase in. Anyway, I wanted to point that out. It's a very neat study that kind of separates it gives you an actual number of risk of cardiac event with LDL, elevation.
Yeah, Ramon, we see this again and again. I mean, the most amusing one was the great Professor Gerald Reaven back in 2001, I think. He published a study. Now, it was not a huge amount of people, around 250 middle-aged people, and they measured their steady-state plasma glucose, which is just the ultimate measure of insulin sensitivity or resistance. And over the following 7 years tracking, the hazard ratio or the risk multiplier for being high in that steady-state plasma glucose, i.e. very metabolic syndrome, was 40 times more likely to suffer illness and death. And in the same study, the LDL was 1.01 times more likely if you had a high LDL. In other words, nothing.
Not even close.
So that was one of the most, but we see it all the time. There's a juvenile metabolic syndrome study. Juveniles in their teens followed up to their 40s for early atherosclerosis and events. And having metabolic syndrome in teenage years was a 15 times risk for future cardiovascular issues and disease. LDL, again, was just nothing. So I could go on all day long that yes, LDL loosely correlates to future poor outcomes, but it's blown away by all the root causes on that yellow box. I mean, it's eviscerated.
Could you mentioned, you're an engineer, you mentioned root cause. As a physician in residency, we're not trained to root cause, we're trained to turn symptoms into chronic disease and pick a medication. Can you explain what a root cause is? And if LDL was a root cause, what would you expect to see? If you dropped LDL dramatically, what would you expect?
Well, if LDL was a root cause, for instance, we wouldn't have people with a lifelong LDL of over 750 at 70 years of age with a 0 calcium score and clear arteries. And we do. We have a family of familial hypercholesterolemics in England, 3 siblings in their 60s, LDL up around 500 long term, all 3 with 0 calcium scores and even 1 or 2 with clear angiograms. perfect arteries. And then we've got people with LDL of 20 with massive atherosclerosis. So a root cause, yes, it's not going to be always perfectly consistent, but LDL barely predicts, and you've got disparities of that enormity. And calcification is the best measure for your current degree of atherosclerotic disease and risk, no question. There were around 20 studies that looked at cholesterol and LDL and calcification in humans, 20 studies. And I think 1 out of 20 showed a linkage between LDL and the degree of arterial disease. So again, I could go on all day. A root cause does not fail most of the time to link to the thing it's supposedly a cause for. It just doesn't happen. Another interesting thing on root cause, though, is temporality. So in engineering, we have a lot of tools. A Kepner-Trago is one where you look at the what is the problem and what is not the problem, and you get distinctions. And you do where is and is not, and when and extent. So if you put in LDL, which was always there through evolution, and your problem now in the 19th, 20th century is an explosion in cardiovascular disease, you have to see a root cause has risen with the problem. But LDL didn't change a jot. Now insulin shot up in the century, smoking shot up in the century, sugar, refined carbs and vegetable oils shot up in the century. They all get a seat at the root cause table. LDL can't get a seat because LDL was there for millions of years, and LDL was the same when your problem exploded. Okay. It can't be in the list.
Thank you very much.
I just want to add to that quickly.
Eric, add to this also if you like.
Just for the root cause analysis, and there was an example given from engineering. There's a much easier one. Let's use diabetes as an example. Clinically, somebody presents with high blood sugar, so you give them a drug that lowers their blood sugar, and they're cured, right? Wrong, because you're only treating the symptom of a root cause. So if the easy one of the things is the 5 whys. You just keep asking why. So why is the blood sugar too high? Well, you're insulin resistant. Oh, why am I insulin resistant? Well, you've been producing too much insulin for too long, and the cells have downregulated the receptors for that. Why has that happened? Well, you have too much insulin because you're eating a diet high in carbohydrate, and that creates, and you're doing that day after day, week after week, year after year, and eventually the cells downregulate after about 10 years. So, and then you get to the root cause, which is diet. So that's just an example.
But I thought LDL was the root cause of diabetes.
Yeah, when you drop LDL, don't you see your blood pressure drop, your triglycerides drop, your waist go down? No, you don't see that.
I'm going to pull one off the live feed here, probably directed mostly to Eric, maybe some other more athletic people in the room. This is pertinent to collagen supplementation in your 60s. What's your opinion on that? It's a pretty hot thing right now.
Yeah, I'm not crazy about that. So you would want, especially if you're going to consume collagen, I mean, it's great for the gut, but as far as for exercise and things like that, there's much better sources of protein, higher quality of protein that get turned into body tissue. At the top of the food chain, it's breast milk, which is hard to get, and then you get eggs, okay, and then fish, and then red meat and things like that. So if you're going to do some collagen, that's fine. I would do it with the meal, but not an empty stomach because it could throw you out of the fast. So there are certain amino acid combinations that are really effective. You get like almost a 95% or 98% absorption rate, and very little of it turns into sugar. But really, if you look at it, there's a lot of protein sources that like half of it is used as fuel and half of it's used as repair of the body. And at the very best, eggs is like a 50-50 split. So do you want to use it for repair? Okay, then why don't you just use like eggs? That might be even better.
Interesting. I had a fun text this morning. So with coronavirus, every egg in every grocery store of my town is gone, and I have an epilepsy patient on a ketogenic diet text me in a panic this morning about eggs. And I have who here has a local egg supplier? That's kind of like a covert egg supplier, you know. You guys out there. So I was able to hook up my friend to my other friend who has chickens, and hopefully the ketogenic diet won't go off the rails during coronavirus. So no, I'm glad to hear it, because eggs versus going out and buying a bunch of supplements for collagen, which are processed. Go get good eggs. I like that answer. Go.
Hi there. I have a 2-part question for Ivor. You've mentioned David Bobbitt's calcium score of around 1,000, and that was, I haven't heard an update on that. I don't know if he's announcing that information. I'd be interested in that.
Okay, yeah, so David originally got, I think it was 900, low 900s, and it's 7 years plus now, and he's got around 4 or 5 scans, and his average increase per year is around 4 or 5%. So we set from the Raji study and other studies that below 15% per annum, you're almost could be taken to be as safe as if you stopped progression or potentially even reversed. So he's at 5% per year, so he's perfectly happy. If he hadn't caught his diabetes and done the research and found out how all this works, he would have piled ahead at probably 25% a year until his inevitable heart attack. So he's happy, 5% a year, he'll take it. But another thing for people, if you're progressing, say, at 10 or 15%, even though you're doing the right stuff, you got to look at the calcium density and the calcium volume. And some people, Mike Eads pointed out this important point to me a couple of years ago. Some people go low carb, he knows they're much healthier, he knows they've resolved a lot of the disease that they had that were driving progression, but there's an inertia. They keep on rising in the score in the following couple of years, but often it'll be that the density number will be rising more than the volume. In other words, the consolidation of older plaque is getting consolidated and dense, and there's not so many new plaques, which is where the volume increases. So there are subtleties and nuances, but that's David anyway. David's happy, as I would be, with 5% a year.
All right, yeah. Over a year ago, I had my mother go in for a CAC scan, and her score was 636. And so I put on her low-carb diet, OMAD, a number of supplements, and 11 months later I took her back in. She was 616. And she had cleared out the left main, I think 40%, the left descending 30%, halved the number of plaques. And the other one was stabilizing mass volume-wise. But the right circumflex, however, had shot way up to about baseline of where everything else had been. So my question for you, in theory, what are possible theories as to, is it soft plaque that has calcified and is stabilizing, excuse me, in that way? Or could it be something else maybe?
So I didn't catch quite all, but her average score reduced somewhat, but she got a lot of regression in multiple vessels, but not the circumflex.
The LAD and the left main.
And left main, but the circumflex got worse.
Yes.
Right, in terms of calcium score for that vessel and in general observation.
In plaque number and, well...
Number all...
No, the plaque number, maybe it stayed the same, I think. I should look back, but
I mean, if you had a big softy in the circumflex or multiple, and they continued to calcify, you could get one vessel, with a lot of soft activity with microcalcification, and then over the year, the processes, the M2 macrophage, the switch to macrocalcification, normal healing processes could be taking place and kind of jump up your score in that vessel. It's speculative, though.
Sure.
That would be a person to go to Arthur Agatston in Miami, because
I was hoping to see him.
Yeah, if you watch my interview with him, and I have more interview to release in the coming weeks, he sees every corner case, every pattern. He has scanned people 40 years ago, and he's still scanning them today, the same individuals, watching their soft grow, their soft stop, their hard plaque. So to be honest, it's an awful pity Dr. Agatston couldn't be here, because my God, that'd be a question for him.
All right, great. And
he's probably watching.
Yep, fantastic. Maybe I'll talk to him.
We have 2 minutes. We'll take two.
Just one quick question. Volume. So I've been getting scores, or I've seen scores that have mass instead of density. Do I need to do math for that?
Mass is kind of a conglomerate, and I think mass is a pretty good predictor, and it takes into account both, but I'm less familiar than I am with the classic volume and density.
Sure.
I need to look into that more, but I know that the mass that's being included now can have good predictive value. So that's from memory. I'd need to check that mass, may be a relatively good rolled up number. But I'd need to check that, sorry.
Okay,
so much going on the last few months.
Thank you so much. And by the way, the CAC scan is $40 in Kansas City.
$40,
wow.
Yeah. Well, that's the key message to everyone. Like, I believe yesterday I was away and there was a Q&A. What about you have a high score and it keeps going up and you're doing the right stuff? Yes, there are people where there's nuanced scenarios, and again, Arthur Agatston has got all kinds of genetic abnormalities that keep driving disease in spite of insulin sensitivity and all. So it's not simple, but I think for the majority of the at-risk, the score will do the job to tell you the degree of disease, and then you have to achieve below 15% progression per annum, and you need to look to volume and density. And yes, there'll be people who are corner cases that are difficult questions for their doctor, but the big message is we need to get it out there for the majority for saving lives. And also, I would add, if we got mass use of the calcification, not a mass screening program, but people took responsibility for their health and their millions and got the scan, very quickly you'd start answering the LDL questions from earlier, because you'd start seeing the pattern emerge from citizen science that the LDL ain't lining up at all with the reality. So I think that would be another service to society besides saving lives.
Okay, super quick. We have 10 seconds, but we'll go a couple minutes over. Not to put the questions on the spot. But go ahead.
Oh, great, thanks. So I really enjoyed your talk, Ivor, about the inside out, outside in theory and thoughts. And one of the thoughts I had that's going to lead to my question is, okay, well, if the lipid deposition that eventually happens is not coming from inside the lumen and then coming out, as you're saying it's coming from the outside in, I was still drawn by this concept of the vasa vasorum and the fact that blood flow is still getting to that area, potentially in that innermost part of the media, that intima that abuts the media. And then I thought to myself, well, how would diabetes actually be a root cause? Like, what's the pathogenesis beyond, like, for the intimal injury to happen? And one thing I thought, and wonder your thoughts, could it be that it's a disease of the vasa vasorum, that with these hyperglycemia spikes, the vasa vasorum is actually not supplying the blood vessel like it should be, and that this is some sort of compensatory, like, in situ lipid formation that happens somehow when those cells aren't getting, like, I'm trying to get that link for how you get vessel injury to lead towards atherogenesis.
One sentence. Oh, quick answer. So a quick answer, I think the vasa vasorum, and microvessel disease and diabetes, I think the main thing driving all of what I talked about in diabetes is macro hyperglycemia, hyperinsulinemia, intimal insult. That said, if the vasa vasorum trying to do their job through microvessel damage and hyperinsulinemia causing necrosis and death of microvessels, then they'll become part of the hot mess too. So I think there's multiple different spheres of mechanisms going on. It's a good question. It's a pretty detailed one. I think if you have the vasa vasorum coming in, as I described, and being part of the problem in a person who's eating crap and is driving disease, and they suddenly fix everything, I think the vasa vasorum will actually steadily retract out of that area, and you'll go back to having normal diffuse intimal thickness in your intima. That's what I suspect.
Thank you.
Last question, then lunchtime for everybody, or fasting, whichever you prefer.
Hi, I'm Raphael, and my question is for David, but it can be for anyone else on the panel as well. It's my understanding that there's never really been a cancer cell that's been found with normal mitochondria. And usually the defects are such that they shouldn't be able to respire normally. So if that's true, how come there can be so many cancer types that don't respond to a ketogenic diet? Or at least that's the supposition being made. How can we square those two facts?
Right. So just to reiterate the question, you were saying that all cancer cells have malfunctioning mitochondria, but ketogenic diets don't work for all cancers.
I think that's what's being claimed.
Yeah. And it doesn't. I mean, there are some cancers for which you wouldn't want to be on a ketogenic diet because there are, despite what we saw earlier, there are some cancers that actually can consume and use ketones. So you have to be careful about that. So cancer is 200 different things. So to keep the answer short, this is an emerging science. We're learning from first principles. We're going back to looking at cancer as a metabolic disease, so mitochondria become more important in that discussion. It's a very, very good question. Thank you for that. And I would invite you to engage in some research to answer that question. That's what I love about science. Every time you answer one question, you end up with 3 more to look at. So,
thank you.
That is good. Till 1:30, have a good lunch, get some sunshine.